So since 2003, Biosense has been the federal solution for syndromic surveillance and has strived to provide local, state, and federal partners a timely regional and national picture of trends in disease, syndromes, and situational awareness. Recently, the Biosense program underwent a user-centered redesign that is hosted in a cloud environment and governed by the public health practice community at large. This new design offers the public health surveillance community an infrastructure never achieved before. It will also have the multiple functions including meaningful use, HL7 message data capture, analytic tools like Biosense 2.0 and Essence, ability to share data across jurisdictions, and much more. NACHO along with CSTE, ASTHO, and ISDS are partnering to manage the governance and use of this infrastructure and are recruiting states and localities to participate. We are pleased to have with us today Dr. Taha Kass-Hout from the Centers for Disease Control and Prevention to discuss the Biosense 2.0 program. Dr. Kass-Hout serves as the Deputy Director for Information Science and the Biosense Program Manager for the Division of Notifiable Diseases and Healthcare Information at CDC's Public Health Surveillance Program Office. He has over 15 years of experience in health, public health, and informatics. Thank you so much for joining us today.
Thank you very much for having me here today.
When will Biosense be available?
Biosense went live, open for business on Tuesday, November 15th, 2011, a couple of days ago.
Can you give us the basic structure of Biosense?
Of course. So a health jurisdiction can choose to join Biosense in a variety of ways. If a health jurisdiction has its own syndromic surveillance system in place, they can join the system to take advantage of the shared environment. Basically, is a jurisdiction can use the Biosense 2.0 application to aggregate its data to be viewed within the jurisdiction or beyond. There are also some analytics available for that, and time series and maps and whatnot. If a health jurisdiction doesn't have any infrastructure in place and would like to join Biosense because they want to use that as their primary disease surveillance for syndromic surveillance system, we're more than happy to assist them. And by that, you have a captures where the information can flow into there, and there's a series of processes to glean the data and make it available in a way that the health department can use it. And they can still be able to use the shared infrastructure or the application to share with one another. And there's a hybrid in between. You know, some jurisdictions, they have a system, but they want to expand, for example, taking advantage of meaningful use program, adding new hospitals. So it can be hybrid of their system and Biosense. We have heard from several health jurisdictions to date that as economy of scale, and especially in this harsh economy, that they want to use the new Biosense infrastructure as their own syndromic surveillance system end-to-end and help them migrate into this new environment. So that's also another utility of this new environment.
What types of data will Biosense accept?
Currently, we're set up to accept a variety of healthcare or healthcare-related data. The focus this year has been tremendously on the urgent care and emergency rooms because of the meaningful use, taking advantage of a meaningful use incentive program, with more hospitals have the option to share healthcare data from emergency rooms and urgent cares with the public health community. So this will provide a great opportunity to catch this data or capture it and be able to process it and analyze it and take advantage of it. There are other data sources that CDC will be bringing to this new environment, and currently we're negotiating the availability of that to all health jurisdictions. For example, pharmacy prescription sales. We have the Veteran Affairs VA, the Department of Defense outpatient and emergency rooms, the national labs from Quest and LabCorp, in addition to some ad hoc or event-based surveillance through news media and blogs and whatnot, that we provide that as a service in working closely with HealthMap.
And how does Biosense equip LHDs to enhance syndromic surveillance into other public health surveillance activities, like monitoring chronic conditions, risk behaviors, and other data elements potentially available through an HIE?
Absolutely. So there's two parts to that question. One part is the kind of conditions involved. So Biosense, part of the redesign is we're moving beyond early detection into situation awareness, and we're moving beyond bioterrorists to include also all hazard conditions such as chronic, environmental, mental health, and the likes. So that will all be available in this new environment. As far as the HIE question, we're equipped to accept information from a variety of sources and through different channels. So it can be an HIE, it can be a hospital, a group of hospitals. But again, I want to emphasize the data is not coming flowing to CDC, it's flowing to the environment that's owned and controlled fully by the health department. It's their own locker or catchment of this new space.
How does Biosense complement or augment syndromic surveillance between what Essence provides?
That's a question we always get. One thing is we want to make sure that the health community can sustain long term. Part of the redesign, we have heard about a lot of other tools available out there that we're trying to make compatible with Biosense. Essence is one, R is another. There's rods, ears, EpiInfo, Excel, all sort of different things. So the way we're trying to work on these is by making the infrastructure compatible with the tools that public health departments want to use. One effort in particular with Essence that we're working on, which is grew out of the interest from the community, is can Essence be a tool, an analytical tool available in the cloud, available in Biosense 2.0 infrastructure? We're still trying to assess the feasibility of that. The Essence is trying to see if that's a viable option, and hopefully over the next few months we'll start testing if that's available.
What are the advantages or disadvantages of doing that, of integrating Biosense with Essence?
We want to make sure that, number one is we want to assure that the public health practitioners are using the tools they're comfortable using on a day-to-day basis. We're not trying to disrupt that whatsoever. However, there is a critical need that evolved in this redesign as we were adopting a user-centered approach, and we're learning a lot from the public health community, is the value add for something like Biosense, a network like Biosense, is be able to look over the fence, see what's going on in other neighboring jurisdictions, be able to stitch a regional national picture. So that's really what the Biosense 2.0 application focuses primarily on, is that sharing of information, even within your own jurisdiction, providing you with capabilities that you can slice and dice the data. That's different than what Essence can do as far as really just focus on deep analytics of your own data and massaging that data, and do other things kind of like analytic tools. Other analytic tools might be able to do, like SAS and R and Excel and other things. So there's a clear distinction between the two as far as application to application. Now, as far as infrastructure is, Biosense environment as a whole, we're providing anywhere from, you can use the entire environment as your syndromic surveillance system, to where you're only using the application to share data with one another, depending on the maturity of the health department. Separately from this, also part of the redesign, we're able to fund many health departments through cooperative agreements to sustain human capacity that is needed. So you have to really look at the whole program as a whole and the features that we're offering, and that in itself really is very distinct from offering a piece of software, which will also be available there.
So who can see the data in the shared data area?
So that's up to the jurisdiction how they want to share the information with other members, either within their jurisdiction or beyond their jurisdiction. So the level of granularity is assessed by the jurisdiction up front. For example, they want to see more granular data within the jurisdiction, but coarser data outside. And then the users who are allowing the share of allowing the views into their information will have the application can help them set that up.
And what data will go directly from the primary source to the CDC?
The data will not flow directly to the CDC. The data would flow either to the health department if they have infrastructure, and then we can connect that to the new environment so they allow them to share that information with one another. Or if a health jurisdiction does not have a syndromic surveillance system or plans to transition or expand its syndromic surveillance to something above and beyond what they're doing, then there will be a catchment area or a locker space where the information will flow into that space.
Other than the VA, will hospital data go directly to the CDC?
No data would go directly to CDC other than what the health departments allow CDC to view.
And if my jurisdiction wants to participate, who should we contact or what should we do?
For local health jurisdictions, you can contact NACHO. We also have set up the redesign website, biosenseredesign.org, as well as an email, dedicated email at info@biosense.se, and we have staff that will answer 24/7.
Thank you so much for joining us today.
Thank you.